So again, I'm Dr. Haffizulla. I serve as chair of the Department of Internal Medicine at our Dr. Kiran Patel College of Osteopathic Medicine. And now my focus is actually on our health equity projects. I also did serve as past president of the American Medical Women's Association, and this work is, from the labors of many folks coming together. So I'm just grateful and honored to be able to present this today. So just to give you a bit of a snapshot of what we're going to describe, I'm going to talk first about the actual project itself, the Caribbean Diaspora Health and Nutrition Outreach Project, and describe how this translated itself into a population health platform. We'll talk about the growth and impact of the project, elaborate on some of those programmatic successes, and then finally, I'll expand on any opportunities for collaboration. And anyone here is, of course, welcome to collaborate with us. Just to give you a data snapshot of our community here in South Florida, about 41% of all of the Caribbean immigrants in the United States live right here in our state of Florida. And if you look at South Florida, which is where I'm located, in the Tri-County area, which is Miami-Dade, Palm Beach County, and Broward County, about now, it was 75%, now it's closer to 80% of all the Caribbean immigrants in our state live right here. Now, more than 90% of our Caribbean community members came from 5 countries as listed here: Cuba, the Dominican Republic, Jamaica, Haiti, and my home country, Trinidad and Tobago. Now, with all of this being said, there was really a lack of effective, culturally tailored health education materials geared towards the Caribbean community. And looking at these non-communicable diseases, these chronic preventable diseases such as heart disease, diabetes, stroke, and some types of cancer, all impacted by diet and exercise, there was a big disconnect in what was being disseminated and shared with the community, and of course, our cultural, traditions and all of the elements that make meaningful impact in our choices, what to eat and how to stay physically active. And another glaring deficit, and which you would find, of course, in many different studies in many different areas of the world, data categories were really not capturing the race and ethnicity complexity of our Caribbean community. I myself always found myself in the other category, but we found that a lot of our Caribbean Americans or Caribbean immigrant community members were either blanketed or made invisible under larger categories like the African American categories, the other categories, even the Asian categories. So, part of our advocacy is also to help push some of the narrative to ensure that we get more comprehensive in our capture of each individual person so that we can amplify their voices and not speak on their behalf. And this is another data snapshot that's coming from the Caribbean Public Health Agency. It's noted that 8 out of every 10 adult deaths were responsible, non-communicable diseases were responsible for this, right? So that's diabetes, heart disease, stroke, all the diseases are listed. And up to 40% of premature adult deaths were attributed to these non-communicable diseases, these preventable diseases. 1 in 3 of our Caribbean children were obese. And in fact, in Jamaica, about 30,000 children had high blood pressure, were diagnosed with it very early on. In Trinidad and Tobago, again, my home country, heart disease was the leading cause of death. And we found that these preventable diseases are really still the leading cause of death and disability. This is a snapshot of where we started and where we are at this time point in this particular project. So we engage our community members in community-based participatory research, again, amplifying their voices. Really wanted to dive deeper to see what social determinants of health were relevant to the Caribbean community, almost to set this framework to decide what might be needed if we were to redesign some of our heart disease indices, for example, or risk indices, to see what might be playing a larger role than others. So we started off with mixed methods research, where I had a qualitative arm of focus groups that represented each of the top 5 Caribbean countries I talked about earlier. And then the quantitative side involved us disseminating a survey that I'll share a little bit more about in a few minutes. And then after we were looking at that data, we teased the data out to revise existing health education materials so that they reflected the cultural, visual, and linguistic preferences of our Caribbean community. We were able to, just from print dissemination and by targeted dissemination, part of our research also captured areas or common areas where most of our Caribbean communities congregated or where they felt comfortable. So grocery stores, restaurants, community centers, places of worship, etc. So the materials that were created, these culturally tailored materials, were disseminated with, with that data in mind. We were able to at least reach about 1,000 people initially. Then we developed culturally tailored programming, again, listening to our community members, helping to amplify their voices and ensure that we're moving in sync with how they wanted to receive that information and where they felt it was trusted. So did not think this would be part of my repertoire, but I do host a cooking show as well. Again, as an internal medicine doctor with my passion is disease prevention, this was just another way to, again, reach our community members. And again, really celebrate our cultural dishes, but make some small changes, reducing the salt, reducing the sugar, looking at portion, looking at activities, physical activities, and weaving that in. And it became widely embraced. So if you would like to visit our cooking shows and look at some of the resources and some of the programs that came from this particular research, you can visit us at the website listed at the bottom of the screen, nsucaribbeanhealth.com. But we've also engaged in intersectional marketing through social media. We've engaged a very diverse community of team members, not only those represented in the Caribbean, but those who were social influencers, those who had trust and had that relationship, that personal connection with the communities we were trying to reach. We did visual storytelling and many community outreach events. We paired that as well too with leadership positions. So I myself sit as a board member locally with the American Diabetes Association and the American Heart Association. We ensured that we created strategic alliances, and I was grateful to be included as part of, as at least a co-chair of the Lauderdale Health and Prosperity Partnership. In the city of Lauderdale, there's a Caribbean majority community. And so our research started off as mixed methods research back in 2018. That became the population health platform for us to do a community needs assessment. And that allowed us to tease out, again, disease metrics specific to the community there, and to be able to engage community members in a way that we were now able to look at various assets within the community and have our community members actually help to become a part of the public health process to help to solve some of the issues. And we've created significant strategic alliances, as you will see on the website as well, too. So from starting off with a reach of about 1,000, we've now expanded that reach in just a few years to over 15 million folks. We're very proud of that, but we're continuing to build this globally. So the platform here today at Scientex is extremely helpful for us to really cast that wider net to help us to improve our collaboration. Moving on a little bit more, this just gives you an idea of what we did. So the materials that were already disseminated in the community used a platform known as Go Slow Whoa, or using the traffic light to eat right, right? Well, green are the good foods, yellow foods are the ones that you can eat moderately, and the slow foods or the red foods are the ones that are high in empty calories, high in fat and sugar, and those are the ones that you can have once in a blue moon or avoid if you can. And this was actually formulated from the CATCH program, which is the Coordinated Approach to Child Health. And this was a wonderful way. These materials are placed in grocery stores and different areas, restaurants, for example, where you now have a visual depiction of what is considered a healthy choice and what's not. We went a little further with these materials, and I'll show you in a minute what we've done. Now, again, these programs were widely disseminated through the TOUCH program, which is Transforming Our Community's Health. And I was very grateful that for us to revise these materials to give it the Caribbean flair, we were able to capture some of the same partners who were involved in the original TOUCH. So now I'm going to take you on the journey to what we've done. So using the evidence-based cultural insights from our research, we were able to, again, revise these materials to reflect the Caribbean community. This is a data snapshot of what we have retrieved from the PREPARE survey. PREPARE is a protocol for responding to and assessing patients' assets, risks, and experiences of PREPARE. The average age of our focus group participants who also completed the survey was about 43. Predominantly women were involved. Households of median of 3 were involved. Most people who participated felt financially safe, felt they had enough food. One big barrier to healthcare access was cost. We also noted that unemployment was more significantly associated with Haiti and Trinidad and Tobago. We noticed there was a level of stress that was considered a moderate to high level of stress with 37%. And then 42%, or the majority of our participants, felt that they needed to speak to a loved one at least more than 5 times a day. There was more full-time work, and most of our participants, as seen in other research presented here in this conference, had private insurance. Now, again, there were some areas to look at, including the role of the female or the woman in a household, because we noted that throughout our Caribbean research that not only were women making the choices for their families, they also directed, where their family members and loved ones would go for healthcare or obtain healthcare information. What's also very important, which we also found reflected in other Caribbean research that we've done, is most of the trusted health information came from physicians. Most of our participants did not trust social media. They did not trust, some of the other portals for healthcare access. They trusted their physicians, which is very interesting. So we're going to be studying this a little bit more. This is an example of some of the food and exercise themes that we were able to garner from these focus groups. Again, very different sets of foods and exercises than what was represented for the general American community. So if you see here, we have our goat, and we've got cabbage, corn, avocado, pineapple, rotis, which are some of the breads. As far as exercise, walking was favored by all groups. Very interestingly, even though these were 5 different countries, we did a focus group for each different Caribbean country, we found there was immense integration across the Caribbean community. So this allowed us to create a set of materials that captured all of these themes. And then as we disseminated the materials, we waited several months, at least 3 to 4 months, before we launched intercept surveys. The intercept surveys gave us a chance to gauge the effectiveness of these health education materials, and I'll share some of those results with you in a minute. These are some of the other cultural themes that were generated throughout the course of the focus groups. So the organization of the materials on those health brochures and flyers and pamphlets and tabletops, looking at the colors and the logos, looking at the phrases that were used. We looked at the information that we felt, for example, like apples were overused and often too associated with health, and that was not one of the culturally favorite foods, for example. And, walking, as I mentioned, was preferred by many folks, and that was just not something that was preferred. Food equations, for example, should be comparable, like they felt snacks to snacks, etc. The illustrations and pictures need to be representative graphically of the Caribbean community, reflecting that diversity. We also noted that certain elements that were used for size control or portion control, like hockey pucks, was not culturally relevant at all. If you look at other cultural insights, eggs had a bad rap in the Caribbean community. So now we had a chance to actually present the factual information. And we were able to do that. And it was really an eye-opener for many folks. So I'll leave this presentation. This presentation, you will find that the research of the article that we wrote for this is available, of course, through the Annals of Global Health. You're welcome to dive in a little bit deeper so you can see more details of this table in a little bit. So this is an example of the previously already existing materials that was geared for the general American community. These are some of the materials that we wanted to revise using the data captured from our focus groups and from the qualitative arm. And this is something that we came up with. This was the changeover to reflect the cultural, visual, the content preferences from our Caribbean community. So you will see curried goat on there, you would see roti on there, you would see oxtail and stew peas on there, you would see Malta, maybe the sugarcane, Scotch bonnet peppers were on there. All of these things, again, came from the research itself, really amplifying the cultural preferences of our Caribbean community. This is an example of some more of the materials that we were able to revise. These are materials, again, that reflect foods and exercises, language, and the layout. All of this, again, came from the insights of that particular research. And we translated our materials, of course, not only in English, but Spanish and Creole as well. We made sure that these were all available as digital flipbooks, through whiteboard videos, in print form, disseminated widely to the areas that were teased out in the research itself. Again, we paired it with exercise options as well. Wanted to ensure that the exercise options that were represented, again, came from our data, and that the bullets for the different health points related to some of the foods, again, was in the layout that was preferred by our community. You will see here, again, the pictures were representative of the diversity of the families in our Caribbean community, and the foods, again, were very much relevant. We ensured that we even changed the logo to reflect the foods again that were specific to the Caribbean community. All throughout, we were able to represent and highlight, amplify, and really lay out in a way that was visually embraced, not only by our Caribbean community, but in a way that would be embraced by multiple generations, not just from the younger groups, but the older groups and everyone in between. Now we continue to refine these materials, and we use some of our community health projects as a platform to hear more from our community so that we can again make adjustments as needed, and then design other research programs that would align with where the deficits lie so we can tease out that information. So now I'm going to share a snapshot of the INTERCEPT survey data. So you've seen the materials that we created from the research itself, and which was widely popular. We decided to test the effectiveness of it ourselves, disseminating these surveys widely again, and in the areas that we've disseminated materials to see what kind of effect that they had. Well, just a quick question to our community members. Most folks actually went to the grocery store, to the restaurant, or the store at least 1 to 2 times a week, okay? What was most important to participants was taste. If you look at the very top here, 54% of our INTERCEPT survey participants felt that taste was the most effective factor in choosing a food or beverage. If you look at fat and sugar content, that was not much of a priority. So our goal, of course, through the cultural health programming, the cooking shows, etc., was again to show small ways that we can make changes in the way we eat so that we can stave off diabetes, heart disease, stroke, etc. And if you look at the result of the effect on choices in nutrition and beverages, overwhelmingly, if you look at the blue bars, our materials made a significant effect. And then remember, these materials were not available, not here in our community. No culturally tailored materials existed to our knowledge. So this project was the first one to really change or refine existing materials to really amplify the preferences of our Caribbean community. Our hope is, of course, to really reduce diabetes, heart disease, stroke, and all of those non-communicable diseases. So in a snapshot, our project, while it started off as mixed methods research in 2018, has really come very far. We, of course, started, in the academic arena through our interprofessional approach. We actually organized, support, pulled in community members as well to the community part of this. Is all connected in multiple ways. Our publications not only add the scientific grit to this, but it allows us to continue to expand that platform. We've done scoping reviews since then. We've looked at COVID-19 and the glaring amplified disparities that not only existed prior to the pandemic, but was even more evident during the pandemic. We wrote some papers about those pieces, and then we were able to connect with the community in a way that we presented our data in a way that they made a decision as to which priorities they wanted to, help us solve. And not only having them involved in the solutions, but also having them in amplifying the need for uncovering some of the invisible communities out there, invisible based on the way we capture data. A community action involved us, of course, sort of galvanizing the community to form teams and to be able to participate in our work. So we melded the academic environment with the community environment and tied that back to research. Our research is not only an inclusive Caribbean team, but those who were also influencers and decision makers in different organizations. We're looking at the food companies as well. We're looking at the restaurants and the portions that they serve, and all of them are invited to the table to participate. So this all-inclusive intersectional research is really helping us now to translate into policy and to create action behind the data itself. And at this point in time, we are there. We've received more grant funding. We've now cemented relationships with more governments and different city partnerships. I've been a consultant for different insurance organizations, for example. We look at implicit bias training and ensuring that we're taking a comprehensive 360-degree approach to ensuring that we look at all angles to really not only, completely destroy the health disparities, but to improve health equity from a different lens, from the community-centered lens. We then recognized that because we were tapping into communities that were previously underrepresented in medicine and are still underrepresented in medicine, this was an opportunity to have more of diversity in our healthcare workforce just from our connection with those communities. So we actually had an app that was in process. This actually received a patent publication this year from the United States Patent and Trademark Office. It's called Mentoring Minorities in Medicine, or our M3 program. It is a way to facilitate the entry of more minorities into medicine and healthcare. So stay tuned for more on that. And if you'd like to be involved as a mentor or have any special projects or programs that you wanted us to fold into this particular app as it's being built, we would love to have your involvement in that. So this particular system, again, allows us to translate some of our connections into those who are now passionate about this work and want to continue with improving health equity on many levels. So just in summary, this is just a novel way that we're looking at non-communicable diseases, these chronic diseases that can be prevented. Our mission is to promote health and wellness while never muting the cultural components. Our promotion of health equity also involves, of course, advocacy, and we'd like to open up race and ethnicity categories so that they capture the complexity and diversity of our community. This in itself will eliminate many other health disparities that are currently being masked. We want to also expand our work on the social determinants of health and not look at that framework from a different lens and ensure that we are putting our community members really at the center of this research and that we are not doing this research disconnected. We're ensuring that the design of any of our projects and initiatives moving forward has that adaptable approach. And of course, another goal that's tied very much into our Caribbean Diaspora project is diversifying our healthcare workforce, ensuring that knowing that the physician space or the clinician space was a trusted source of health information. We now have an opportunity as well to not only put that at the forefront, but ensure then that the conversations that you're having are culturally relevant, that there's a level of trust, that there's a level of camaraderie and collaboration in that relationship. Here is just a snapshot of some of the publications that we've done. You're welcome to read some of these, and we've explored many different avenues, and we're continuing on with several other projects that you're welcome to collaborate on. You could reach me by email here if you'd like to collaborate with us in any capacity. I look forward to hearing from you and looking forward to learning lessons from each of you as we continue to amplify and build this work. Thank you very much. It was such a pleasure to speak today. I appreciate you, and I'm happy to answer any questions in the chat box.
Mrs. Chairman, okay. I thought I could ask a question right now, but okay, if it's impossible.
Sure.
May I?
To ask a question?
Yes.